Welcome to INEDCAST, your getaway to the latest insights in education, healthcare, and innovation. I'm your host, and today we have an exciting episode featuring a distinguished guest from across the globe. Joining us is none other than Dr. Anil Arora from Sir Ganga Ram Hospital, India. Dr. Arora is a renowned expert in hepatology. He delivered a thought-provoking talk on the pathogenesis of hepatic steatosis, insights into potential treatment options. Today, we will dive deeper into his groundbreaking perspectives and as he answers the most pressing questions about fatty liver disease and its cutting-edge therapies. So sit back, tune in, and let's explore the future of liver health with Dr. Anil Arora on INEDCAST. Dr. Arora has the unique art of putting together complex theories, complex pathophysiological mechanisms in such a simple manner that everyone can understand.
We have so many well-known hepatologists who have special interest in the field of fatty liver disease in particular. I see Dr. Deseja from India, and there are many other, and here from United States as well, Dr. Jalal, Dr. Pragdala. So I will pull them into this discussion. So starting with Dr. Deseja, your comments and any questions as well, please. Dr. Deseja.
Thank you, Sanjay. And I think I also must compliment Dr. Arora for this wonderful talk. And he always does a good job, but especially he does a better job when it comes to, pathophysiology of any condition. I think, as always, he has done a wonderful job. So maybe just one or two points from my side and maybe one question to Dr. Arora. He did touch upon, the issue of autophagy, which is so very important now. And to be more specific, maybe it is a mitophagy, which is, the dysfunctional mitochondria, which are not, working well. So since this was related to the drugs, I just wanted to add here that the drug which is approved, the resmetirom, in addition, resmetirom has been shown to improve this mitophagy or autophagy, that it removes the dysfunctional mitochondria and induces new mitochondria. So that is one, but in addition, the major action of resmetirom is that it improves something called the cellular hypothyroidism. So that's why, there's a concept of cellular hypothyroidism in mast cell D, and we know that this is a thyroid hormone beta receptor agonist, and this has been shown to improve the cellular hypothyroidism, improves autophagy or mitophagy in general. So I think that was one thing. The second comment would be, about the precision and the personalized medicine, which is now coming up in the area of mast cell D. And we are all aware of a clinical trial which is ongoing by AstraZeneca called the Fortuna study, where they are picking up patients, those who have PNPLA LA3 variants, and then these patients are then being given what we call the ASO molecule, the antisense oligonucleotide molecule, to tackle this mutated variant. And then, because this has been shown in mice by this ASO technology, that if you target these mutated PNPLA3, you can improve the fatty liver. That was my second comment. And the last is my question to Dr. Arora. The one group of molecules, again, which is coming up in a big way, other than which he touched, is the FGF21 analogs. So in that setting, again, and this is a question maybe in general and particularly for FGF21 analogs, that why do within the same class of drugs some molecules will work and others will not? For example, say let's talk of FGF21. We know there was an initial molecule by BMS called pegbalfermin, which was not effective, but then the picozafermin is effective. Efruxifermin, which is coming up, looks effective. And this may be a story within the FXR agonists also, that some work, some do not work. So rather than having a class effect, there looks to be a more than that. So my question to you would be if you can address that based on the pathophysiology. Thank you very much.
Yeah, excellent. I'm happy that Ajay, you are here. You are the master of NFL all over the world, and we really have a lot of regard for you. Coming on to your first question, that was on, what was the first comment on?
cellular hypothyroidism.
Yes. In fact, the reason I didn't touch on treatment aspect was because in any case, this total pathophysiology of development of the fatty liver was so complex. I didn't want to touch upon individual drug. Now, resmetirom is a specific T3 receptor agonist, which primarily acts by 150 times onto the liver compared to the periphery. Again, by acting as a thyroid agonist, it is increasing the mitochondrial oxidation. But if you see the way I have explained how the mitochondrial oxidation, because of the upregulation of the UCP2, is leading to the exhaustion of the mitochondria by itself, because so much of it is coming. And every time you tend to have beta oxidation, 5% of the time you will produce free radicals. You will have reactive oxygen species. The more you try to cause oxidation, the more will be the production of ROS. I don't know how that injury will improve. But as you very rightly said, it has so many multiple actions other than increasing beta oxidation. By, as you said, it increases the replenishment of the mitochondria, it decreases the apoptosis. And I've shown you at multiple places where it acts. We still do not know whether it is a thyroid alone effect which is occurring or it is occurring at multiple levels. And the second is FGF. Now, FGF1 is a agonist, is a very good molecule called pegozafermin, which has been recently published by Rohit Lumba group, in which it has been shown this is the only drug which has shown to decrease fibrosis in patients who already have developed fibrosis. So this is a drug which increases the insulin sensitivity, changes the uptake of the glucose, and decreases the pro-inflammatory cytokines. Why it acts at a particular level in terms of different molecules acting differently is possibly there may be genetic polymorphism of so many other mechanisms which are occurring within the cell. That may be the reason why a particular molecule occurs in a given individual and another does not occur.
May I invite Dr. Jalal, Prismin Jalal from Baylor?
Oh, thank you. It's an outstanding talk. We learned a lot about biochemistry and immunology. Now, and because Ajay is still here, right? So in terms of genetics, as you see, there are a lot of variations throughout the world. In Hispanics, and they're obese. I'm sure some environmental factors there. In India, we used to call lean NASH. It's the same gene, PNPLA3. So, and obviously there are other few genes involved, including this TM6, SF2. But the question is, if the same gene is involved, why do you think, this question to both of you, why do you think so much variation in the presentation in different parts of the world? I mean, is it the pathophysiology remains the same, genetic susceptibility remains the same? Why do we see so much variation? I mean, are we missing anything else in terms of pathophysiology? Because the presentation is different, aggressiveness is different. What else is going on?
A very good question, sir. My answer is simple. I don't think we should attribute all the problems which are occurring in the liver related to one single gene. If you look at whatever I explained right from the beginning, there may be hundreds of the enzymes, hundreds of the proteins, hundreds of the polymorphisms, which may be ultimately leading to accumulation of the fat and subsequent disposal at multiple levels, either in the form of accumulation of the VLDL, extrusion of the VLDL, oxidation into fatty acids. So I think PNPLA is just one single marker, which only, so far as I'm concerned, it contributes only minimally to the pathogenesis. It is just a marker. I don't think it could be the cause of the whatever is happening within the liver. That is the reason, even if it is present, I don't think you can attribute much to it, unless, as Ajay said, if you are able to do with the use of ASA, you are going to alter and see prospectively by altering the PNPLA mutation, how does it affect? But I think it is quite downstream. There is so much occurring upstream. I think the contribution is not much.
Thank you. Yeah, there's so much to learn. But genetically, the presentation is different, although it's the same gene. That's what my question was. But I agree with you. There's so much we still need to work on. Ajay,
Thank
based
you.
on your experience, any comment? And obviously, you have published on it a lot.
Ajay, the AIG group has a lot of publication. Dr. Rao's, PM Rao's group has a lot of publication.
Oh, I think
How
as rightly put by Dr. Arora, the predominant contribution in the pathophysiology for MASLD are nothing but the environmental factors, which are, or your cardiometabolic risk factors which contribute. Yes, genetic factors are important, but that how much are they contributing? I think probably we need more data on that. Yes, in a person who's genetically predisposed or has variant genes, there obviously he would be at a higher risk, even with slightest of cardiometabolic risk factors in comparison to somebody he's not, who's carrying, not carrying the variant genes. So I think this needs more data, as I said, more work on this area. And this one study which is going on will not answer all the questions. We would need more data, and there could be an interplay of various genes within the PNPLA3. You have a variant which is protective, you have a variant which is, which is pathogenic. Similarly, you have TM6SF2 HSD is protective. So what is going on between different genes, the interplay between different genes, I think would also merit, I think. So we need probably more data on this.
Thank you.
Thank you. I have a question to Dr. Arora, and maybe Dr. Desaja can also chime in. The two distinct groups of the patients with fatty liver disease, one is the lean NAFLD and the obese NAFLD. Now, there has been a lot of studies showing that the progressions of the disease are also different in these two groups of the patients. So when we learn this complex pathophysiology, is there anything predominant pathway or any predominant pathophysiology that has been worked out in lean NAFLD that you'd like to share? Because treatment-wise, it could be different. So many pathways are acting. So the drug that might be working for the obese NAFLD may not be for the lean NAFLD patients. Any comment on that?
Yeah, I think very relevant, Sanjay. Answer to that is, whenever, as I started, that adipose tissue by default is an area which is supposed to store your energy, which is in surplus till you're able to eat well. So you need to have a healthy tissue. Now, if you have energy surplus and it keeps on getting beyond the arenas of adaptability, then you develop a obese, sick, fatty tissue. That is how you develop a typical type of NASH. But in patients who have a lean NASH, you have a fat which is already diseased. So you cannot have a lean NASH which does not have an adiposopathy. They already have a diseased fatty tissue. That means even in normal stores of the fat cannot be stored. Majority of these patients have insulin resistance. Majority of them will have metabolic syndrome, and it is unlikely that you have no metabolic syndrome, no insulin resistance, still lean NASH. Lean NASH means a sick fatty tissue, not because of the overutilization by the incoming fat, but because of the metabolic processes or because of the genetic abnormality. That is lean NASH. That is the reason once you have lean NASH, it will pour in a lot of fat within it will not be stored within the fatty tissue, it will come into the liver, into the circulation. From the circulation, it will come into the liver. So it amounts to the same thing. The only difference is, to begin with, it is disease compared to getting over-exhausted because of the obesity. That is the difference.
Thank you. Dr. Desai, do you have anything else to add on that comment?
No, not really. I think he's covered it so well.
My question is, there are some studies that have come particularly from India as well, that fatty liver NAS occurs even without insulin resistance, at least a sizable proportion of patients, and at least some of the studies that came out. How do we explain in those group of patients this pathophysiology?
I showed one of the slides very clearly that for fatty liver to develop, you do not necessarily have to have insulin resistance. Fatty liver per se causes insulin resistance. Not always insulin resistant will develop fatty liver. It depends on adaptability. I have shown you the fate of incoming fatty acid. It can either be stored as TAG, or it can be extruded as VLDL, or it can be utilized in other various processes. So depending on where the problem lies, if you have insulin resistance, that same quantum will go up. So if you have a problem of overeating, so not all obese will be having diabetes, not all obese will have insulin resistance. That increasing fat content coming from the tissues, increasing fat coming from the, say, diet, that will also contribute to development of the fat liver. So insulin resistance is not must for development of fatty liver disease. But once you have fatty liver disease, because of the production of the saturated fat or DAGs or ceramide, you are more likely to develop insulin resistance.
So in that case, the treatment that we choose, would it be guided by a degree of insulin resistance or and certain pathophysiological markers that we have to identify, because these patients may not respond if they have been acting on a different pathophysiological mechanisms?
Absolutely. Ajay very clearly said, now we are moving to a personalized treatment. That could be personalized treatment. If we understand this pathophysiology right from the word go, whether the fat is coming from the diet or it's coming from the diseased adipose tissue or de novo lipogenesis, or whether there is a component of insulin resistance, that is so important in managing the patients. Because ultimately, what we do as hepatologists today is we do not have any drug for NFLD. Ultimately, we end up to, other major components of treatment include weight reduction, lifestyle, exercises, control of diabetes, control of hypertension. Why is it that? Because that is all is contributing. Because there are so many factors which are contributing to pathogenesis of fatty liver disease. Unless you understand why this is occurring, one single drug will never be useful, because it is occurring, and fat is coming from multiple sources and it is being taken care of by multiple mechanisms. There is so much of adaptability. Once everything is exhausted, then you develop the disease liver. So you get on to the basic cause. That is the reason till now there is no drug which takes care of NFLD.
Thank you. Dr. Raj Burman from the United States.
Thank you, Dr. Satpathy. Dr. Arora, excellent talk. I would like to steer the discussion, or I would like to ask a question, moving from theory to practical. Basically, asking a question about your second last slide, where you said that depends what stage patient is presenting. So in the Indian paradigm or in your OPD, when you see a patient coming in, let's say an obese patient, and has either no fibrosis or early fibrosis, and assuming those are non-diabetic patients, after you have given the counseling for diet, exercise, avoidance of alcohol, and before you send them for bariatric surgery, what is the sequence in which you use different kind of drugs in an obese fatty liver patient? And also, if you could say the same for a lean mast cell patient, how do you approach these patients practically in your OPD? Thank you.
I think Ajay has given a very good algorithm for us to use in OPD. But just summarizing that, once you have a patient who has obese and simple fatty liver disease, you make an assessment what is the degree of damage to the liver. You have non-invasive tests for assessment like FIB4 or a fibroscan. Most of us tend to do fibroscan, which is easily available in a tertiary care center where I practice. Try to assess whether the patient has a simple fatty liver disease or patient has a NASH or or has already developed cirrhosis. If there is no NASH, as evidenced by lack of any rise in ALT or any fibroscan reading which is substantially more than say 7 or 8, you treat it as obesity with fatty liver disease. Then the whole concentration is on reducing the weight, making the patient understand the reasons for development of the fat, and switching on to the lifestyle changes. We have started a new concept of fatty liver clinic alone in our hospital, Ganga Ram Hospital in Delhi, and I had informed Ajay also about it. And we make all efforts, and I'm surprised that 20 to 30% of the patients do substantially lose weight. In BZOPD, you may not have time. Even if you lose some weight, it does help. At least the lifestyle changes, and then you go on. There's only one drug which is available for us to use in other than vitamin E in patient with NASH is a drug called saroglitazole, which has limited utility. If you look at it, it acts at the alpha and the gamma PPARs. It is more useful in patients who also have diabetes and have dyslipidemia. But in NASH alone, it has limited efficacy. So far as drugs are concerned, we have hardly any pharmacotherapy. We go by assessing the degree of damage to the liver. If it is NASH or non-advanced fibrosis, simple lifestyle changes, it is what we do. And then look after the metabolic factors like dyslipidemia, fat, etc. In lean patient, again, I said, most of our patients will have metabolic syndrome, and accordingly you handle them. Most of them will either have insulin resistance or metabolic syndrome. I'm yet to see that rare entity of fatty liver occurring in an absolutely downtrodden poor man who has nothing to eat, then he has fatty liver. I think that era is gone by. So most of our lean patients do have an underlying problem.
Thank you. Are you using semaglutide in your clinical practice for managing these patients with NAS?
Yes, not for NASH, but I am using it for weight reduction. In fact, I am a big fan of a GLP-1 agonist, especially in patients who after lifestyle interventions fail to lose weight. I have with me Dr. Parveen and Ashish in our liver clinic. They're doing a good job. And because it is available as oral formulation in the 3, 7, and 14 milligram as a tablet called Rybelsus, oral form we are using for reduction of the weight, not as a part of treatment of NASH.
Thank you. And I see there are several compliments on the chat box about this complex talk, and but there are a few questions as well. One question is coming from Dr. Kalko.
Yeah, clinical marker for fatty acid oxidation. Can you have any bedside or?
Please go ahead.
Yeah, you cannot have a marker. You see, after all, it is a very complex pathophysiological cellular mechanism which is occurring deep within the cell. So the beta oxidation of the fatty acid occurs at the level of the mitochondria, peroxisome, and cytosome. So there is no counterpart for clinical evaluation on the bedside or laboratory means. If there is something on an experimental basis, I do not know.
And there is a question from Dr. Manoj Joshi. Role of S-adenosyl methionine in fatty liver disease. I think you did briefly touched, and you can elaborate on it.
So this is a drug which is supposed to replenish methionine and choline, which are so important in formation of the choline, which is an important integral component of the cell membrane. So the deficiency of this leads to more vulnerability of the membrane, especially the mitochondria and the plasma cell membrane. And hence, this is supposed to be a hepatoprotective agent. So all said and done, said or unsaid, most of us are using these drugs because that is the only drug which is available for use other than UDCA and S-adenosine methionine. But randomized trials somehow, either because of the poor quality of the trials or because of the lack of the efficacy of the drug, somehow not given convincing results so that it can be put as one of the frontline drugs to patient with NFLD. But theoretical bases are good because there is nothing else to offer. We keep on using it. That is where it acts.
Thank you. And we have one, I believe, last question on the chat box is from Dr. Bhatt, Sunil Bhatt. Is any role of obeticholic acid in the treatment algorithm at present?
You see, OCA or obeticholic acid, it came with a bang in the market, and everybody was, just jumping around saying that we have found a wonder drug for treatment of NASH. But because of the significant side effects which were associated with it in the form of dyslipidemia and reduction of HDL and significant pruritus, the drug has gone out of the book. So it is no more used. In fact, when we started using it in the doses of even 5 to 10 milligram, in fact, the pivotal trials which were published by Arun Sanyal and Rohit Lumba's group had used a dose of 25 milligram. But in our Indian scenario, we have a availability of drug in 5 milligram tablets. So even 10 milligram will give you severe itching. So severe itching, dyslipidemia, and altered lipid profile were the deterrents were used, and that is the reason US FDA has not allowed the use of this drug. And the further trials, I am told by Arun Sanyal and Rohit Lumba, have been stopped. So I think practically it should not be used. The only indication in which you can use it in a subgroup of the patient with primary biliary cirrhosis. But my worry is that in primary biliary cirrhosis, the major problem is itching, And if 25% of the patient with OCA develop itching, then how would it be useful?
Thank you again. And I think we have another question come from Dr. Nipun Verma. Nipun, would you like to ask the question?
Yeah, very well. Thank you so much, sir, for the excellent talk, as always. I just wanted to have an opinion of yours. Endocrinologists always keep on saying that there is a class of obesity called metabolically healthy obesity. And they tend to say that subcutaneous fat is much better than the visceral fat. And so, in your opinion, is there any way we can identify a patient who can progress, like an obese patient with fatty liver who's likely to progress, and patient doesn't have any significant fibrosis as of now, his risk factors is controlled, so as to we stratify these group of patients for active surveillance, or we put them on drugs? So idea is to identify the patients early before they progress on to fibrosis or liver related complications, even before fibrosis.
Yeah, very relevant question, Nipun. Thanks for joining. My answer is very simple. You see, if you have listened to the whole talk, at every stage, the body has been making all efforts to have the adaptability. It is making every effort so that the injury to the liver does not occur. It increases beta oxidation, it increases UCP coupling, it causes increased excretion of the VLDL, it tends to cause autophagy, it stimulates T cell. It is all, once that is exhausted, then you develop this clinical phenotype of NASH or cirrhosis. The concept of metabolically healthy obese is, I think, is a useless concept. It's just a question of time. Every single metabolically so-called healthy obese is likely to come down. It is just a question of time. So what will depend on what is the further stress which is going to give you trouble? When will this patient tinker on to development of inflammation? When will the adaptivity end? And what are the enzymes or the genetic mutation which will stop at beyond a particular point, which will tell us, oh, no more adaptability. Now you have insulin resistance. Now you have a lot of ROS. Now you have ER stress or mitochondrial stress. I think if the patient is metabolically healthy, obese, why not make him lose a weight? Make him understand sooner or later it is just a question of time that you are going to develop. And the rate of development is dependent on so many factors of adaptability at different levels. Entry into the liver, oxidation into beta, into the mitochondria, oxidation into cytochromes and peroxisomes, exit from the liver, degree of generation of the toxic metabolites. You have no control. So if you have a patient who is metabolically active and obese, I'll spend all energy, time, and money for helping him reduce the weight rather than trying to find out the reason why would he develop diabetes.
Okay, thank you, sir. Just a small more question that we understand that even patients with MASLD, not more in India, but at least in Western countries, consumes alcohol. So do you think the drugs which are actively working in this area would also work in some forms of alcohol-associated liver disease?
Absolutely. You see, what I have shown you is a compensatory processes which tend to take care of any inflammation. There is nothing sacrosanct about the fatty liver disease. It is just one trigger. After all, mitochondrial stress, ER stress, or depletion of the free radicals or generation of the ROS, it is a common phenomenon which will occur everywhere. In alcohol, see, it is a self-inflicted injury, but downstream signaling, other than by one or two pathways, is almost the same. I think so many agents which will take care of the process in case we find out how to suppress pro-inflammatory cytokines, how to increase the production of IL-10, how to increase the production of TGF, decrease the production of TGF beta, the pro-fibrogenic cytokine, that will be useful in any condition, be it alcohol-induced injury or drug-induced injury. These are the common downstream signaling which will be useful in everybody. The trigger to start the processes may be different.
I must thank you, sir, for your talk. I love that idea of stage the disease and find out right patient and where the patient lies, and treatment should be given according to that. Thank you so much, sir. Thank you for the talk.
Thank you. Again, I got a question from Dr. Yaswant Kumar. Which pathway is most important target for future drug? Dr. Kumar. Anything else if you want to add before Dr. Arora answers the question?
No, sir. Thanks a lot. It was a really nice talk. And actually, I am a biologist working on NFLD. So my concern is to target future pathway, like which pathway is more prone to disturb in during the NFLD progression. So that's why I asked this question.
Can I answer it scientifically or philosophically, Sanjay?
Whichever way you like to answer, that's fine. I think we have time.
Best pathway we need to correct is the lifestyle pathway. That will take care of everything. Stop alcohol, take care of your body weight. That is the answer. None of the other pathways will ever be useful. If you see the downstream signaling as mentioned by Nipun, it is almost the same. Whether it is COVID or any infection, the downstream pathway is almost the same. So let's take care of the lifestyle. That is the single most important pathway we have to do. Maybe one has to act at the level of the brain.
Thank you. That was beautifully answered. And Dr. Burma, you wanted to ask a question again? I saw your hands raised momentarily.
It's okay. It's okay. Thank you.
So, well, I think if there is any other questions from the audience, one thing I would like to commend, Dr. Arora, your talk was beautiful, very well explained, but the discussion part was even better. And I see, many of these talks that we have done in the past, I've not seen the audience is glued to this long and without much attrition. They really stayed until the end to listen to the discussions, and I think they all enjoyed it despite the complexity of the talk. So really would like to thank you from the bottom of my heart, and on behalf of INEDCAST, would like to thank you as well for coming into our forum. This is wonderful. And people who missed this talk can listen to this talk at a later time. We can put it on our website with the permission from Dr. Arora, and let us know if you have any other questions. I can forward it to Dr. Arora as well. They can email Dr. Arora and those questions. Thank you, Dr. Arora.
Thank you. Thank you, Sanjay.
Thank you all.
Thank you, everyone.